What did you say? Are we live?
We are live now, Doctor.
Okay, okay. So, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in. It gives me immense pleasure to welcome you all for the 11th masterclass of the online PG teaching program, which we have named Kaksha. Kaksha by ROS will cover all major topics over a period of next 2 years of the current curriculum of PG teaching in India. We'll be bringing the best of national and state faculty experts to share their knowledge and interact freely with you. The residents also are encouraged to put forward their doubts in a fearless manner, type in the chat box, ask questions. Coming to this class, we have today with us my dear friend and who will be threadbearing a major. Unni, in brief, is an authority in retinal imaging and diagnostics, and will be introduced by Dr. R.K. Sharma sir, who is our esteemed panelist for today's Kaksha. Dr. R.K. Sharma sir is one of the senior most vitreoretinal surgeons of North India and has a huge experience in complex medical and surgical retinal disorders. I also welcome the executive ROS president, Khilani sir, president-elect Sir Dr. Sanjeev Desai, and our dynamic secretary from Jodhpur, Dr. Ghulam Ali, for today's class. Our hot seat all final year postgraduates from different colleges in Rajasthan. And the most exciting part is the grand quiz, which is at the end of the class with exciting prize. So keep a strong vigil and listen carefully. Over to R.K. Sharma sir to carry forward the Kaksha and read out the lengthy CV of Dr. Unni sir. Dr. R.K. Sharma sir, over to you.
Thank you, Dr. Vishal. And first of all, welcome to Dr. Unnikrishnan Nair. Dr. Unnikrishnan is a renowned VR surgeon from Kerala and is attached to Chaitanya Hospitals. After his fellowship from Shankar Nethralaya, he went to Sydney Eye Hospital, Australia for advanced fellowship, and he is also a fellow of Royal College of Glasgow. He has many named awards to his credit and is keenly interested in retinal imaging, as Dr. Vishal said, and his retina imaging clinics are very popular and very well attended. So thanks, Dr. Uni, for sparing your valuable time. And I have the honor to invite you to this session. The screen and the class is all yours. Please share your screen, Dr. Uni.
Okay. Thank you so much, the Rajasthan Ophthalmological Society and R.K. Sharma sir. Thank you so much for the kind introduction and the invitation, and Dr. Vishal too for making it possible. So I'll be just sharing my screen now, and yeah. I hope it's visible.
Yeah.
Okay. So the topic was neovascular AMD. And
yes, visible.
And the one thing about neovascular AMD, as we were discussing, is that it is being diagnosed by everybody now, and as it should be. Everybody should know how to diagnose AMD. And but it is not a simple disease that just means anti-VEGF. There's a lot of intricacies in it. And from a perspective, I would like to treat this like a Hollywood movie, which is every movie, after the movie, you eventually make a pre-movie or a prequel, and then you have multiple sequel movies. But to outline this talk in a very lucid way and hopefully gain some insight, further insight into just not a simple disease called AMD, let's go through these various steps. So first we'll be discussing, as usual, the pathophysiology, which will be a little bit theoretical, but there's a lot of nice stories inside this. So these are some cartoon pictures that I've taken up from the internet, which show where the disease is and how we should look at it. So if you can see in the deposition part of the disease, like drusen and all those things, the disease process lies in between the laminae, between the Brooks membrane, the RP. And then you have the neovascular disease, which is between the Brooks and the choriocapillaris initially. So the site of the disease process is essentially closely related to the retinal pigment epithelium, and the RP, being the most metabolic cell, is the so-called culprit and the victim of the disease. So there is a host of etiopathogenic factors, of which age obviously is the most important, genetics, smoking, and hypertension, and basically an abnormal lipid profile as a start to the disease. So that is the origin, the how it occurs. One of the most important things we have to understand is that there is a genetic predisposition to AMD, of which the complement factor H pathways, or the abnormalities of the complement factor H, or the CFH, and the two, basically the disease being an interplay between environmental factors, aging, what we call a retinal age gap. There is a difference between the retinal aging component. And then you have genetic variations all causing various diseases. To put it in a small nutshell, there are two genetic components, the ARMS2 and the HTRA1, of which the HTRA1 is most associated with neovascular AMD. So that's a very important thing to know, that there are two or three gene locuses, the complement factor H and the ARMS HTRA. These are just theoretical, but it's very easy if you can just think of HTRA and hemorrhagic. Now, where does a disease process start? The disease process, as there's a retinal aging gap. There is a specific retinal aging where different parts of the retina ages at different times. The choroid has its own aging process, or RP has its own aging process. So essentially, first there is a floor, there's a background where there is choriocapillary insufficiency. And this causes a lot of changes in the RP Brooks membrane complex. And the essential thing that happens is that it's a lipid metabolic problem. That is, it's not a lipid metabolic disease, but local lipid and lipoprotein clearance or lipoprotein metabolic damage in a very small, distinct area. That is the RP and Brooks is what causes a whole sequence of diseases. So you can imagine underlying choriocapillary insufficiency, indirect damage to the RP and the Brooks complex, altered lipid metabolism would be the main thing, of which we have just mentioned that the retinal pigment epithelial dysfunction forms the basis in which the lipids, which turn over as a part of the vitamin I cycle or the lipid-related visual cycle, have an altered metabolism. And what happens in this is basically there is deposition in areas where it shouldn't deposit, initially between the laminae of the Brooks, which is called the BLAM D, and eventually they form something called basal linear, that is blind. So these are just a few basics. A very nice picture that shows first you have deposition in between the RP base and the Brooks, which is called the basal lamina deposits, and eventually you have deposition inside the Brooks complex, which is called basal linear deposits, and which is the basis or the Brooks or the drusen damage that happens. So as we mentioned again, there are genetic susceptibility, age-related where the homeostasis, the RP slows down, there's impaired lipid changes, there's local inflammation called para-inflammation or immune activation or complement factor, and all of this causes oxidative stress or damage on a very cellular or microscopic level to all the, let's say, the basal laminae of that supports the RP and the retina. So essentially, to summarize again, the RP ingests cholesterol and exudes cholesterol in a cycle. When the cholesterol or the lipid component or the apoproteins cannot be eliminated, they get deposited, and the site of damage is essentially in and around the Brooks membrane or the supportive membrane to the retinal pigment epithelial cell. So as we said, when there is deposition, there is increased thickening. Therefore, there is increased diffusion distance between the choriocapillaries and the end result. The choriocapillaries has to provide oxygen nutrients to the RP. There's increased distance, and essentially, one, there is a poor choriocapillary circulation, and two, whatever the choriocapillary wants to take to the RP, there is increased distance and defective diffusion. And therefore, as we mentioned, there are two types of deposits. One is the basal laminar, and two is the basal linear deposits. This is a wonderful picture that shows over time the what happens, and there's at the base we see one of our culprits, a type 1 MNV, which we'll be coming to later. So over time, the pathogenesis causes a failure of the RP. And along with that, photoreceptor death. This is one sequence which goes into the dry AMD component of advanced AMD. But what we are more interested is the second component we're discussing today. That is a wet AMD component. So for all, an interesting piece of information is that wet ARMD or wet AMD is the most commonest form of any neovascular process in the body. So what we are dealing with in AMD is a very critical pathophysiological change that happens in tumors and second in AMD. There are various neovascular stimuluses that happen, and basically the whole disease is from a dysfunctional or damaged RP. It's an RP cell-secreted VEGF. Combined with that, you have the thinning or the damage to the RP barrier. The integrity is lost, and it allows VEGF to be a polar secretion of VEGF to happen, which eventually is responsible for the new vessel formation that we see. So basically, we have a VEGF accumulation, which sprouts new blood vessels. These blood vessels, not being of competent nature, they leak proteins and lipids which are responsible for exudation, either in the form of edema or in the form of heart exudates. These fragile blood vessels do not have a maturity in their walls, and they can lead to hemorrhages. And eventually, whenever you have a vasculogenesis happening, it can probably lead to a fibrosis eventually, and that is the end result of your AMD. So in a sequence, you see proliferation, leakage, hemorrhage, and eventually a fibrovascular scar formation, which is the end result. And all of these changes are due to an increase and a polar secretion of vascular endothelial growth factor. So why does the neovascularization happen? This is what we need to understand. It is a cry for help from the RP and the choriocapillary insufficiency. So it's a rescue mechanism, basically. And like all rescue mechanisms, starting from a small scar becoming a keloid, it is an overcompensation that leads to all these changes of neovascularization in the sub-RP space. And why does this happen? This is a very important concept to have. Why does the body attempt to make the neovascularization? It is a compensation for choriocapillary insufficiency. That is, new vessels happen in the sub-RP space and the subretinal space to provide nutrients, oxygen, all the rest as a result of the lack of the above. And therefore, we can call it a recapitulation of the choriocapillaris. When the choriocapillaris is lost, the neovascularization produces a new vascular complex to provide nutrients. So from this, let's have a bit of interaction from our people in the hot seat. You've understood one basic concept about neovascular AMD, and that is the rescue nature. So can you, based on this, can you typically tell me where a neovascularization usually starts in the AMD process? Can I have one of the people in the hot seat? Is it between
below
the RP, below the
Brooks membrane?
Excellent. So you can imagine that this is an overgrowth from the choriocapillaris, which is the closest source of blood vessels growing into the place underneath the Brooks. Okay, so that is what happens first, and we'll come to that later. Okay. So now,
Dr. Uni,
yeah.
The question that should come to everybody's mind is, okay, you have explained us very well that neovascularization, what is the cause of neovascularization, but most important is, why is macula the most commonly affected area in the retina by this neovascularization? Why not the peripheral parts of the retina?
So we have two typical things happening. One is the most metabolically active RP cells are at the fovea. The most sensitive choriocapillary circulation is at the fovea. So you have basically in AMD, there has to be a milieu where there is a high oxygen concentration. And that oxygen concentration with the formation of lipid damage, oxidative free radicals is what causes endothelial cell damage, what causes RP damage. So the cycle is heaviest at the metabolically most active part. That is typically not exactly at the fovea, but in a small area around the fovea, that is a perifoveal zone, is where most of the age-related diseases start happening.
Exactly. And this is because of the oxidative stress, which is most likely to happen at the macula or the parafoveal area, because the light is most of the times getting or maximum amount of light gets onto the macula. That is one of the proposed hypothesis why macula gets affected. And the demand is also very high, as you rightly said. And the oxidative stress is also very high on the fovea and parafoveal area. Is that correct, sir?
Yeah, that is right. And there is one more very nice topic to be thought of here, is that there is a protective protein called heat shock protein. And this protein, there is a genetic decrease in this protein in AMD sufferers. And that is one of the reasons why the protective mechanisms are fail in the parafoveal or the foveal area. Okay.
Yeah.
So
sure.
Shall we continue, please? Or shall I continue?
Sure.
Yeah, fine.
Anybody has any other questions? Thanks. Go ahead, please.
So typically, when we go to the next point about AMD, we think of when the disease starts. So the disease is a disease of the central vision, as we've just mentioned, and it starts in the early stages with metamorphopsia or distortion, micropsia or change in shape of the vision. The image becomes smaller, or if a bleeding happens, it ends up in a scotoma formation. So let's go to the second part of the prequel, a non-NECNVM or a non-exudative CNVM. This is a little bit of an advanced topic, but it's brilliant to explain what is happening. So in any neovascular AMD process, two things can happen. You can either have angiogenesis, which you see on the right, which is small capillaries, new capillaries or new small vessels form. And there is another process called arteriogenesis, where nothing new forms, but pre-existing vascular capillaries open up. So this is very important to know that in a non-neovascular AMD, one of these two processes can happen. And this is something I'd like to show you. Here you can see a small bump in the RP complex elevated, which we call a double layer sign. There is no fluid, but on OCTA, which will come in detail, you see a small vascular twig over there. That is, there is no fluid exudation, no CME, no SRF, but there is a vascularity. So, like the question we asked to the resident in the hot seat, where does the disease process happen? And this is probably the disease process starting in a non-exudative CNVM, which is a very hot topic nowadays, a non-exudative, that is the CNVM in the absence of SRF or CME. So why is it so? You can see here there is a small vascular network which is picked up by this examination technique called OCT angiography. And this is the next thing I'd like to, a beautiful image that shows point one, a healthy retina. The second picture, you see a vascular membrane growing between the Brooks and the RP, and later it leaks fluid and becomes a typical wet AMD. So by definition, a non-exudative CNVM is a treatment naive, that is non-treated type 1. It is divided into a quiescent or a subclinical, which we'll come to later fast. But basically, this is what it is. There is no evidence of intraretinal or subretinal, and for at least 6 months. So by definition, this is a pre-exudative. One of these is a pre-exudative stage. That is the prequel. That is a precursor of a wet AMD. And it usually takes about 6 months to convert into an exudative stage. The non-exudative CNVMs are divided into many types. We'll just go through, but this is what we see. There is a VEGF drive and the neovascularization forms. Through the Brooks, it breaks into the sub-RP space. The sub-RP space is a very potential space. And in the sub-RP space, the neovascularization grows laterally or sideways for some time. It increases horizontally. And that is what is called the double layer sign, or a shallow irregular PED, or by name it is called many things. But eventually, when it starts happening, this is what we're talking, the growth of a CNVM. The blood flow is very slow and it is compensated, so it doesn't exude. But as more and more blood vessels or angiogenesis happens, more blood flow happens and it starts leaking. Like I said, the blood vessels are leaky. They leak fluid, they leak hard exudates. And this is the pre-exudative stage and going to an exudative stage and all the features of a CNVM. So sometimes if it exudes early, we call it a pre-exudative stage of a CNVM going to happen. But sometimes this vascular membrane just sits over there. And that is when we call it a quiescent or a inactive non-exudative CNVM. The dye signatures will come to later exactly like type 1 membranes. We've got more presentations regarding that. The OCT looks like this DLS or a double layer sign. That is a separation between the RPE and the Brooks. You can see this is a double layer sign, which is very important, which says that there could be a neovascular or a wet AMD about to happen, which is being harbored in this separation between the RPE and the Brooks membrane. It's a very important sign. And then there is another sign called FIPED or flat irregular PED. It's the same thing, which is slightly bigger. Whenever you see something like this with fluid, you can imagine that there is a vascular membrane underneath it. It has also been called SIRE or shallow irregular RP alter elevation. So we have three names, DLS, FIPED, and SIRE, which are sometimes interchangeable, which indicate a non-exudative or an exudative CNVM lying underneath between the Brooks and the RPE. And these have OCT signatures also. This is a small picture where you can see the CNVM without exudation. So this is a precursor to a wet AMD. This is the importance of this particular lesion, non-exudative CNVMs. These are multiple pictures where you can see vascular things on the test called OCT angiography. And these are precursors. I'm just going to skip through these slides. So this is a very important, in all the AMD patients. Sorry? Okay.
I think, okay, go ahead.
Okay, I'll continue. I think this is a very important slide, which says that in all of AMD patients, it has been reported in some groups up to 25%, but the most largest study says 3% of all the patients you see could have a non-exudative CNVM, okay? But more important than that is this slide, which tells you that nearly 20% of patients in the non-exudative stage can convert to full-blown wet AMD in 12 months. Another study says nearly 50%. So let's say between 20% to 50%, that 50% of your patients who don't have exudation, if you can pick up a non-exudative CNVM, they will convert to a full-blown wet AMD in a 12-month period. And before they do, the vascular network grows suddenly in size. And as I said, there are two types. Some of these lesions are based on angiogenesis with small network-like capillaries. Some are based on arteriogenesis, which are more stable. They're more mature vessels. And these are opening up of pre-existing capillaries. So you can see the difference. On the right-hand side, on the left-hand side picture, you can see very small capillary networks happening. And you can see it more clearly, a very network lacy pattern. This is a wet AMD. And on the right, you see more filamentous things. And this is a more stable, mature vascular complex. So these are the same two pictures showing the network. I'll just go through these fast. And one more important sign in AMD, which is highlighted in this non-exudative lesion, is a dark halo sign. And what is it? There's a darkness around the CNVM. It's a very interesting sign to know what is happening. If you see in this particular picture, you can see that there is a darkness around the CNVM. This is a vascular steal phenomenon. The CNVM is stealing blood from the choriocapillaries around it. And that is why you get a darkness around it. And that too is a very important thing to understand CNVMs, that it could be either a primary choriocapillary loss or the choriocapillary damage around it could increase because blood is being stolen by the CNVM from the choriocapillary around it. So this is non-exudative CNVMs in a nutshell. They could be pre-exudative lesions. If you identify non-exudative CNVMs, you should see the patient very frequently for at least 6 to 8 months, nearly up to a year. Look for OCT signs of cystoid macular edema and fluid to see the conversion. Why? The earlier you pick up a CNVM, the earlier you treat a CNVM, the better results your visual acuity gain you are going to retain. Now, let's come to the plot per se. What is the disease? So, the disease, as we know on the left-hand picture, wet AMD, the most typical is the presence of subretinal blood. How do you notice subretinal blood? If you see hemorrhagic lesions and you see overlying vessels, that is the simplest definition of finding subretinal blood. Sometimes you can see exudation, that is heavy lipid exudation. As I said, the vasculature is not mature, it is leaky. So it can leak fluid, which we call cystoid macular edema or SRF, or sometimes it could leak exudation. And sometimes you can have all these elevations happening, which is the RPE elevations because of sub-RPE fluid accumulation. So these are some of the basic clinical characteristics. This is another thing which you can see very dark hemorrhagic lesions. The darker it is, the more likely it is to be sub-RP hemorrhage, hemorrhagic pigment epithelial detachments. The picture on your left shows another sequelae, that is a lot of RP atrophic changes, which is the end result of any AMD disease, whether it is dry AMD or wet AMD, the disease is progressing towards atrophy. Other lesions could be RP tears and deciform scarring, the result of fibrosis as the end of angiogenesis. So I want to say this is a very important slide for all the postgraduates to know. If you get confused between type 1 and type 2, just imagine that the disease is starting from the choriocapillaris capillaris and going up. Till the RPE, it is called type 1. And when it breaches the RPE, it is called type 2. Now, please understand that the type 1 and type 2 is a terminology used for CNVMs, choroidal neovascular membranes. There is a type 3, but it is not called a type 3 CNVM. Why? Because the type 3 disease is not choroidal in origin. The type 3 disease is retinal in origin. Therefore, by a common classification or international acceptance, the terminology is now slightly changed to MNV1 or macular neovascularization 1, which is equivalent to type 1 or classic or occult, type 2 MNV, macular neovascularization, and type 3, which is also called RAP or retinal angiomatosis proliferans, the previous term. So this is the new accepted classification or new accepted terminology for AMD to divide macular neovascularization into type 1, type 2, and type 3. So as I said, the type 1 lies between the Brooks and the RP, doesn't breach the RP. The type 2 has breached the RP and lies in the subretinal space, causing a lot of subretinal and intraretinal fluid. And the type 3 is like a linear structure which starts from the retina and eventually reaches the choroid in the choroidal new vessel membranes. So the type 3 is like a full thickness choroidal abnormality. So let's just go a few words upon fluorescent where we go. The fluorescent in a classic is very classic. It's what we call a lacy pattern. It is well defined. It's very important. There are two terms you have to keep in mind when you think of fluorescent angiography in classic CNVM. Early, you pick it up early, and it is well defined. Now, this is the same thing that will help you differentiate a lesion when it is an occult CNVM. We'll be showing the pictures also. Occult usually does not come early. It comes late. It is not well defined in the early stages. You see it in the late stages better. And we'll come to RAP later, not now. So basically, an angiographic classification of CAM would be classic, where you call it well-demarcated lacy pattern with late leakage. An occult lesion will not be well seen early, but in the late phases, you can either see poor staining, a stippled staining, or a late leakage, which you haven't seen any time till the last frames. So this is how a classic would appear. In the early phases, you see the outline of the lesion, and as the dye progresses, it becomes more and more well-defined. So if in AMD, only basically two phases of the angiogram are important: an early phase to pick out the extent of the lesion, and a late phase to pick out the intensity of dye coming inside. Other lesions that can be identified are serous PEDs, hemorrhagic PEDs, and drusenoid PEDs. Let's look at a drusenoid PED. A drusenoid PED is basically fluorescent staining soft drusen. So here in the clinical picture, you see soft drusen, and from all the stages, you see the lipophilic material of the soft drusen getting hyper. Again, you look at the early phases, you look at the late phases, there is no leakage, there is no fuzziness, which tells you that the lipid material is just absorbing the fluorescent stain, and that's how you call it a drusenoid PED. A serous PED is slightly different. You can see a PED over here. A serous PED is like you're pouring something into a cup and you're keeping on pouring it. In the initial stages, you see the outline well, and it gets more and more well-defined as you go into the late phases. But if you notice, there is no spillage outside the cup. You can think of the PED as an inverted cup. The intensity of the fluorescence keeps on increasing, but it doesn't go outside the cup. So that is how you understand what a serous PED is on an angiography. Now you have a fibrovascular. So if whatever I said about serous PED, just throw it out of the window, and then you get a fibrovascular PED. You don't have a definition in the early stages. Different parts of the PED stained with different intensities. Why? Because some of the PED is fibrous material, some of the PED is vascular material, some of the PED is serous material. So you have a very variegated or different staining characteristics in the PED, and that is a fibrovascular PED. The next investigation basically for diagnosis is ICG angiography. ICG is different from fluorescent because it is more of a test to find out choroidal circulation rather than retinal circulation. And by this, we use to see the more choroidal disease. You can imagine occult CNVMs are beneath the RP, more closer to the choroidal circulation. Therefore, ICG was very useful in it. So here, what you see on these pictures is that you see the fluorescent on the right-hand side. It's a classic lesion, which you see very nicely. But in the angiography, you don't see it well. In the ICG, that is a right-hand picture of the double picture, that because classic CNVMs are picked up better on fluorescent than on ICG. This is a very key point. But if you look at this particular picture, which is an occult, that is the lesion is a type 1 beneath, you can see you don't pick up anything at all in the fluorescent, which tells you in the early phases there is no particular membrane, but you see a kind of diffuse patchiness happening in the ICG, which is the picture I'm just showing you over there. And as you go to the late phases, you see a very intense spot in the ICG, which is a focal leak. This is one of the characteristics of an occult CNVM, that is having a focal leak in the late stages. So let's just this is a very important, simple caricature or cartoon to tell you how a type 1 or classic is. That is, there is a breach and it grows into the subretinal space, and all the features are because of that. So let's look at this. This is an autofluorescence picture which shows you the black is the hemorrhage, which blocks it, and you can see a whitish lesion over there. And as you see the angiography going, you can see in the earliest phases, you can see a well-defined outline. And as this angiography goes through, you can see the outline is maintained. But one of the characteristics, you see a fuzzy margin. So if you look at the margin I'm showing you, you see the intensity increasing and you see a fuzzy margin. So how to identify a classic CNVM? The early phases, you see I'm just repeating this because it's really important. In the early phases, you see the outline, the intensity increases, but the whole shape doesn't change much. And in the late phases, you see fuzziness at the edges. This edge is obscured, but this edge you can see fuzziness, which tells you this is a classic CNVM or a type 2 CNVM. Again, a close-up picture where you see the fuzzy edges. Over at this corner over here, you can see the fuzzy edges. And this is how a classic CNVM appears on OCT. It's a fusiform lesion. You can see a fusiform lesion on the OCT. This is another example where you see a well-defined lesion coming up early, and later you can see fuzziness at the edges, obscuring the margins, but it has not increased too large or change shape from the early definition. And again, let's go through the same thing again and again till we get mine. In the early stages, you see the outline of the lesion. And as the lesion goes through time and you go to the late phases, you see fuzziness happening at the margins. The margins are obscured, but the whole size of the lesion doesn't increase much. Again, there's the tendency to form a fusiform lesion, and that is a characteristic definition. So these are just another things. And this is an OCT angiography where you can see the net. This is a dye-less angiography test where you can see the physical characteristics of the net better than just the fuzziness. Now let's go to the occult. In the occult, the lesion is typically underneath the RP. What does that do? You can imagine that the entire angiographic characteristics are slightly smudged or hidden by the RP or the pigment of the RP. And that is responsible for all the angiographic features we are seeing. That is the lacy pattern, the well-defined margins are obscured by the RP. You can just look at this picture where you see a lot of autofluorescence, a lot of white and black and all these things happening over there. And please look at these pictures, which are very important. In the early phases, you just see a lot of dots. You don't see any particular lesion happening there. And in the late vision, this is called stippled hyperfluorescence. There's a stippling. You don't see a particular well-defined lesion. And why is that? Because the entire RP is covering the lesion and the definition of the lesion is not as clear as if it would be above the RP. So you have a physical characteristic explaining the fluorescent characteristics here. That is underneath the RP. It's very important to keep this in mind. Here again, you don't see any particular lesion. You see a small margin here. You don't see anything. It's just a lot of stippling. Hyperfluorescence is just coming out. But in the late stages, you see a lot of dye. So why is it important to look at the early and the late? As I said, if the early corresponds to the late, it is more likely to be a classic membrane. Because in the classic, as I said, the form is given earlier. Here you can see there is not much hyperfluorescence, there's much more hyperfluorescence. The form is only revealed in the late phases. And that is a very important sign for you to diagnose occult CN waves on a fluorescent angiography. Again, you see this picture, you see the fluorescent angiography, the OCT, the disease is beneath the RP. Here you see the early pictures, you don't have any definition, but as you go, you see a larger area of fluorescence. This is a typical example of how an occult would be. Early does not correspond to late. A simple thing to keep in your mind to diagnose occult CNVMs. So this is again something that we call a late leakage. Nothing in the early, nothing in the middle, but in the late you see a small area of hyperfluorescence. Another point. So early doesn't correspond to late or nothing till the late stages. These are the two things that would suggest that the fluorescence is suggestive of an occult CNVM. And in this particular patient, there was a pigment epithelial detachment, which was probably fibrovascular and responsible. The other test that we use commonly is the OCT. And these are the typical lesions. You have a lesion here. This is subretinal fluid that is above the RP. This is intraretinal fluid. And this is a RP detachment or sub-RP fluid, it is called sometimes. These are various lesions where you can see there is a separation between the Brooks and the RP. Here, the disease is underneath the RP. So this is a type 1. Here you can see some amount of disease above the RP. So this is a type 2 component is there also. Again, examples where you can have large type 2 components, which causes a lot of edema, intraretinal fluid and subretinal fluid. Now let's go to the angiographies of a few. This is a scar. You can see the scar very clearly. But as we do the angiography, you can see that it's picked up the entirety of the scar stains. And later you can see a little bit of fuzzy margins over the hair, which shows the scar is still active. And this is how a scar looks on OCT. This, sometimes you may feel that it is a CNVM. But if you look the late stages, early stages, what difference? There is no fuzzy margins. The margins are very well defined. This corresponded to an area of pure atrophy where the RP was lost. This was basically a window defect or a transmission defect or the choriocapillary circulation coming through a lack of the RP. So here, how do you differentiate? You can see there are no fuzzy margins. It's a well-defined RP margin, okay? This is an example of a rip. Here you see the choriocapillaris. Here you see the retina. So basically, the retina has the RP has ripped from here to here, causing a crescentic shape. And how do you know it is a rip? Because you have there's no exposure here, and you can see this is a high autofluorescence picture. There is no RP here, and here you see the retina is over here. So I have a few slides on type 3, which I'm not going to go into detail. Basically, type 3, I'll show you here. You see a PED, but you see a lot of dots over here, which shows there's a retinal component to this PED. Circulation happens from above. And this is an example of the thing. It's a retinal lesion which starts growing down. And the last stage, there is a connection between the retinal component and there's a subretinal component also. So there's a lot of things about obvious, but I just want to show you this. This is the typical background disease and how to suspect a RAP. When you have a lot of soft drusen, but this is not subretinal blood. This is intraretinal blood. So I would like to emphasize that when you see a lot of drusen like this, with the presence of intraretinal blood, you should always suspect this particular lesion. And why I want to show this is that in the early phases, just remember, you see an early dot, which is a retinal circulatory problem. And then you see the CNVM happening. And this is why it happens. You have a retinal component, a serous PED. And so this is the constellation of features for a RAP. Intraretinal hemorrhage, cystoid macular edema, a serous PED, and a retinal component. So I'm just going to skip all of these because RAP is it's slightly out of the pivot. I'll show you this video of an angiography which shows a RAP. And here I'd like you to look at these 2 points. Early in the angiography, when the dye is going inside, you see one point becoming hyper fluorescent in both the ICG and in the fluorescence, which shows that when the retinal circulation is filling, there is a spot happening. And later, as you see in this spot, you can see the CNVM coming up in the late phases, both on the angiography. So there is a connection between the retinal circulation and the choroidal circulation. And this is what we call MNV3, or previously called RAP, or type 3 macular neovascularization. So just skip these pictures and we'll just go to another important thing that we use, that is characterize OCT and OCT angiography. So this is the most important test nowadays for diagnosing AMD or wet AMD. Why it is important is that you get structural characteristics of the vascular disease. You can see this blood vessel very clearly. This is dyless. The OCT images are converted, multiple OCT images are converted into a recreation of the blood vessels based on the flow of RBC. So when the RBC has flowed through the CNVM, it has been picked up by the OCT or OCTA. This is another example where you can see a vascular network. And this is a beautiful example by the OCT. You can see that this looks like a classic membrane. And without dye test, without FFA, without ICG, you can pick up the vascular network or CNVM over here. So you can see that the current, this is one of the most important things that a resident should know now, is that the OCTA has turned out to be one of the most important tests for diagnosing AMD nowadays. Here you see a clinical lesion with subretinal blood and a scar. And now with the OCT angiography, without the use of dye, the entirety of the vascular network has come out now. So this is a typical characteristics of a type 2 membrane. You can another beautiful pictures you can pick out choroidal new vessel membranes with OCT angiography. There are 3 characteristics that are loops, anastomotic channels, and what we discussed earlier, the hypointense halo or the choroidal steel that happens around the CNVM. Here you see small anastomotic channels, and you see loops, and you see the choriocapillaris around the CNVM is darker, which shows choriocapillary loss. This particular image shows, you can imagine the small blood vessels going into the sub-RP space over here. subretinal space. And that is how a classic CNVM looks like on an OCTA. So let's go to a type 2 or a classic. Has a lace tooth pattern. It is very fine, very intricate. You cannot see the gaps. It's so densely adherent. And that's how all these are images of type 2 CNVMs. So structure flow correlation, let's skip all of this and we'll just go to a few images. This is again, you can see a choroidal neovascular membrane, and this is the corresponding image. You can see it over here. A lot of applications of OCTA, which is basically out of the scope of this presentation, but I just want to show you how easy sometimes it is to identify. Here in this OCT, you have a lot of things happening. You have subretinal fluid. This is probably subretinal blood. But when the OCTA, you can just pick out the membrane very easily. So as I said, well-defined membranes are very characteristic of type 2 CNVMs. These are other images. You can see the angiography has a lot of confusion happening over here. There are dark areas, white areas over here. But when it goes and you do a OCT angiography, every vascular network in that is seen very, very, very clearly. So that is the importance and advantage of OCT angiography in diagnosing WetAMD. So there are the typical two patterns which is required for an exam point of view. They'll ask you what are the two patterns. One is a Medusa pattern and one is a CFAN pattern. The CFAN pattern is where the feeding vessel is on the side and the CNVM is on one side. The Medusa pattern is where this is a CFAN, it grows to one side, and the Medusa pattern is where the trunk is in the center and it goes all around it. So these are the two patterns, CFAN and Medusa pattern. There's another example. This is a Medusa where it goes all around, CFAN where it grows only on one side. So again, there are a lot of things. When you have small vessels, lots of anastomosis and loops, it is an active lesion. When it is so-called a dead-tree lesion with very vascular things, it is thought to be a regressing lesion. In a type 1 CNVM, you have larger vascular loops as compared to type 2, where you have small vessels. So just now, let's look at the sequelae. The last part we're going to, the sequelae of a CNVM, is basically when you treat it and when it recurs, sometimes it recurs. And when it recurs, you have these small vessels growing at the side. So this is an important feature to diagnose. This is a partially treated CNVM, and when it recurs, you have all these small channels forming. So that's how a CNVM regresses. When anti-VEGF is given, the maximum effect is in 7 to 10 days. By the 16th to 18th day, there's maximum vascular shrinkage, but it starts to regrow by the 21st day. And by the 28th day, some part of the vascular network is regrown. That is why we have to supplement it again with anti-VEGF on a monthly basis. This is the rough life history. And when it grows again, you see all these small vascular channels regrowing in a CNVM. This is a recurrence. Again, you see this is called a loops happening, the interconnecting loops. And this is what happens in a recurrence of a CNVM. That is, after it shrinks, it regrows again. In this particular lesion, you can see here it is regressed, but on this side, it is recurring. So in one CNVM, you have a regressed area, and the same CNVM, you have a recurrent area. So again, the same theme, small vessels indicate angiogenesis happening again. So let's look at the next sequelae, that is scarring. Scarring occurs when the vessels become so thin over time, over multiple treatment, that they become very filamentous. If you look compared to the previous pictures, you don't have those small vessels. There are long filamentous vessels, or this is called a dead tree appearance or a pruned tree appearance. You don't see any small vessels, only the big, large vessels. So this is the appearance of a regressed CNVM. And another thing is called, it becomes like a skeleton. That is, it becomes fragmented on OCTA. You see all these fragmented appearances. So these are the two appearances, a dead tree appearance or a fragmented appearance. Okay. So we'll just skip all these slides because it's the same thing and just look at some of the other simple characteristics in OCT. So you know that a PED is an elevated lesion, and here you have substance underneath. So this is a fibrovascular PED. Here you have a PED with a new terminology or a new thing called multi-layering. You see something happening over here, multiple layers. So this is called a multi-layered PED. All of these have small significances. You see these lines, these are multi-laminate or multi-layered PEDs. They have a small significance, which we'll come to later when we discuss treatment. So all of these things, this is another example of multi-layering. You see multiple layers happening over here. And can anybody venture to guess, is this a good sign or a bad sign? Can I have one of the, do you think it's a good sign or a bad sign? Multi-layering. Okay, we'll come to it later because it is an important thing to know nowadays. So I'll just skip that. And this is how a serous PED sometimes looks. As I told you, it's a white, like a cup is being filled. There's no change. This is a large PED and you don't see the base. So this is how a hemorrhagic PED looks like. You don't see anything at the base of the PED. At this particular area, the RP is missing. So this is how a hemorrhagic PED, because there is blood inside, the OCT does not transmit. So this is another feature of AMD. It's called a hemorrhagic PED. And this is an example of a tall PED, a tall peaked PED. One of the important things of seeing a PED recur is that if a PED or a pigment epithelial detachment you see and it comes back, it is a sign that it is a sign that the disease is recurring. So another sign of the disease that we should know is called ORT, or outer retinal tubulations. What are these? I mean, can you see these small circular bodies over here? So why knowing this sign is important is that this is a sign that tells you stop treatment. This is a sign that happens when the disease, their photoreceptors are trying to form a circular pattern. They're trying to degenerate. They're degenerating. This is not edema. This is a sign that tells you slow down on treatment, basically. If you can see this particular, this is photoreceptors forming a circle to protect themselves. And the same thing is called degenerative edema. That is, you have lesions like this, which is not active cystoid macular. This is all degenerative edema. That is edema that is overlying a scar. And you don't go to treat this kind of edema. You have to stop treatment at that particular time. Another feature of AMD is called SHRM, or subretinal hyperreflective material. Why? Whenever you have, it is just an OCT terminology, where whenever you have like this hyperreflective area, you see this very, very bright spot over here underneath the retina, this particular spot, it is called SHRM, or subretinal hyperreflective. It can be blood, it can be fibrin, it can be cholesterol deposits, whatever it is. On OCT, it is called SHRM. And why it is important is that some of this SHRM over time does not go away. Some of the SHRM goes away, but sometimes it just gets established. And when it gets established like this, it becomes a scar. So SHRM sometimes is a precursor of scar formation. That is, you see the SHRM over here, it is getting well organized, well shapely, and it becomes a scar. And the scar, as I said, is one of the final outcomes of wet AMD. So the poorer outcomes of wet AMD is the presence of CME. When a PED comes back again, when you see SHRM and it does not go away, that is, whenever you see these hyperreflective components keep on being there, it is bad prognosis. So now I'm just going to go through treatment. Treatment in AMD is very simple and very complicated. I would like to tell you this in a story format. Okay, there are lots of studies, but I'm not going to go into any study, just the names. The first study was the MPS study, the macular photocoagulation study. The story behind it is that it gave us definitions. It told us, what do you mean by visual loss? What do you mean by classic, occult, predominantly, all these lesions? It defined distances. What do you mean by subfoveal? That is exactly under the fovea. Juxtafoveal, 1 micron to 199 microns, and extrafoveal beyond. So it told us all these definitions that we're still using now. That is the MPS study. But basically what it told us is how to laser. The first form of treatment for CNVMs was laser. It told us that you could laser extrafoveal CNVMs, that is away from the fovea, and still have good vision. You could treat some juxtafoveal CNVMs, that is very close to the fovea, but you shouldn't, or if you treated subfoveal, you would have visual loss. But it offered you the first form of treatment for a CNVM. That's the take-home point. The definitions were there, and but the problem is that sometimes you could never truly laser off a CNVM. You can imagine if you do thermal laser to a CNVM, you're destroying RP, you're destroying viable photoreceptors and all those things. Therefore, you are causing visual loss. But the point here is that if you don't treat it, the CNVM would expand and your scotoma would increase. That was what the first MPS study told us. The first proper treatment was PDT. It used a dye called vertiporphin, and it was photosensitization. There was to avoid collateral damage to the surrounding retina. That was PDT. There were many studies called TAP and VIP and VIM and all those things. But basically, all I want to say is that PDT offered the first treatment in which the vision acuity did not drop by much. Laser caused drop of visual acuity. PDT first gave us a treatment in which the visual acuity did not drop. So just when it is not of very high relevance now, but essentially it said that PDT was good for classic lesions, and for very small lesions, essentially PDT was better than for very large lesions. So around 2005, 2006, till 2006, PDT was the only thing we had, and we used to do a lot of PDTs. But then eventually we went into the anti-VEGF era. The anti-VEGF era is a story of studies. From each study, we gained some knowledge till we got the knowledge we have now. The first studies, the Marina and Anchor, told us that anti-VEGF prevented severe visual loss. It's a very important point. Marina and Anchor study told us to give anti-VEGF monthly. So the first regimes, the first anti-VEGF treatments were all monthly treatments, and the visual acuity results were fabulous. For the first time, people were talking about improving vision, which happened in about 30% of patients with anti-VEGF, which was, before that, it was unheard of, people gaining 15 lines of vision, 15 letters of vision with a treatment. Till then, we were talking about not losing 15 letters. Now we're talking about gaining. So both these treatments, the Marina and Anchor, told us that, yes, you could improve vision with anti-VEGF. And this is just a slide. I hate describing this, but you see this going up and this going down. The white one was without treatment. You lost so many lines. Because of anti-VEGF, you give each of these is a monthly dose. These studies told us that you could gain vision. So again, to the point, the Marina and Anchor told us that we could gain vision using anti-VEGF monthly. Then we thought we started getting a little bit lazy. That is the cost factor, the fear of side effects. A study called Pierre, which said that let's try giving it only 3 monthly. So that was the first lesson learned. When instead of monthly, you gave it 3 monthly, vision dropped after the initial gain. So this is the Pierre. After the initial gain, the vision dropped. Forget that graph. Monthly was the gold standard. When you gave it 3 monthly, according to Pierre, it didn't work. The vision dropped again. So that was lesson number 1. That is, you need to monitor and probably give it frequently. Another study called Excite said the same thing. There's a study called Sailor, which said that you just no need to see the patient monthly, see the patient quarterly, and it gave catastrophic results. The vision drop was tremendous, which eventually the dictum was that however you treat the patient, you really need to see the patient on a monthly basis. And from there came the most important study, one of the most important studies that dictate how we treat it now. See the patient monthly, look at the characteristics, clinical characteristics mentioned below, look at the OCT, look for new development of hemorrhage, and based on your clinical findings on a particular day, you do PRN, that is as and when required, or prorinata. And this was called the Pronto study, that you see monthly and assess based on that time's visit. The implied meaning was, if you could give the injection monthly, it was the best, but at least monitor monthly and treat according to the clinical and the OCT features. The reality struck that we give too many injections, and therefore we started combination treatment. We started bringing back an old treatment called PDT and combining with the anti-VEGF and seeing how good it was. It was good. Why? Because it reduced the number of injections. So starting from monthly, we went to Pronto, then we went to combination therapy, especially with a study called Everest and Everest 2, which told us, yes, by giving PDT along with anti-VEGF, we could reduce the number of injections without a lot of visual acuity loss, which was important also. Another important study was a CAT trial, which compared all the available injections and told us something we knew. Giving monthly was the best. Giving PRN was second best. This is a critical study of relevance now, which is called the fluid study, which says that you do not have to treat an AMD till there is absolutely no SRF or absolutely no SRF. You had to treat any cystoid macular or any intraretinal fluid, but you did not have to treat till the absolute drying of the SRF. Why? Because the more anti-VEGF you gave, the more possibility of causing atrophy was there. So you could leave a little bit of fluid. It's a very controversial study, but it could dictate the future of how we treat it. The new drug on the block is brolucizumab, which is found to be structurally, some anatomical outcomes are better. But there are some warnings about brolucizumab nowadays. Surgery was a total non-starter. It was a starter, but it did not continue as a treatment methodology because the outcomes were not better than not doing anything. In the era of anti-VEGF, surgery is not a good option. So, I mean, this is basically the entire. I have a few more slides regarding how to some algorithms, but I think we can stop here and we can take some questions regarding it. And maybe if we have time, we can go to the next part of it. So can't hear you, sir.
Any questions from the hot seat or other residents? Sangam. No.
Do we have any?
No questions. So can we have the quiz then?
Okay, fine, perfect. So, I mean, just before that, I mean, a small thing on my part, I would like to invite everybody for our imaging conference, the Retina Imaging Congress that happens in 7th or 8th of July. We have a wonderful faculty this time. I hope all the postgraduates and residents can make it to Trivandrum. This is in July. And I'd also like to invite you for the Vitreoretinal Society of India conference that is also happening in Trivandrum in December, which we have the honor of hosting this time. So, yeah. So, I don't know. I mean, I've made a very, I've got 3 quiz questions. One is difficult, yes, but 2 should be picked up. Let me see how good the residents are. So, but even if you don't worry, I'll ask you a simple question after that. So I'm going to show you 3 images. Okay. So this is the first image. The left is a multicolor. The right is a fluorescent angiography. Okay. The second is an OCT image. The third is an OCTA image where you see what I've described. And I'll leave you with this image of the other eye. So can anybody tell me the diagnosis of this patient? I don't know how the quiz works. So, I mean, whoever comes.
Whosoever writes, gives the answer first, gets the prize.
So I'll show you the images one more time. This is the color. You can see a small hemorrhage. I'm describing it. You can see a small whitish area. In the angiography, you can see a leak all around that area. Here is the right eye picture where you can see some spaces in the retina and a small fusiform elevation. And on the OCTA, you can see a vascular network. And this is the other eye.
We have got few answers, Uni, but you have to tell me what is the answer, correct answer according to you. Then we can decide who is the winner.
Okay, so this is a patient where there is a hemorrhage and a whitish area around. And by this angiography of all we've talked about, you can see a fuzzy margin all around. So there it is likely to be a classic CNVM. And here you can see a fusiform elevation, but these spaces are very characteristic of a disease which is present in the other eye. This is a vascular other eye also. So this is a macular telangiectasia with a CNVM. It's a MacTel CNVM.
So the right answer and the first person to give this answer is Narendra Meel. So I'll write down his name. So he gets the first prize for the first question.
Okay, that's great. Congratulations, Narendra.
Congratulations to Narendra. Can we go to the second question then? Yep.
The second question is that we have a lesion over here. And you can see the lesion's a circular lesion in the center. You can have, there is an elevation over here. And you can see this is the OCT where you see an elevation. And this is the autofluorescence where you see a lighted up area. So again, there is a yellow spot in the center with an elevation that looks like subretinal fluid. And autofluorescence shows a bright area. And I can give you a clue. This is one of the mimics of CNVM. So do we have any answers for that?
Yes, we have got one or two answers, but we'll wait for a few more seconds.
Sure, sir.
So can I tell you the answers we got on the chat box?
Sure, sir.
One is the first one is best, then adult onset vitaliform deposit, serious PD, best disease. So most of the people have said it to be best disease.
So probably it is very close to the answer, best disease, but more accurate would be adult vitiliform.
So
best can also be taken.
This adult onset vitiliform deposit was is given by Narendra Meel. He has already got one prize, so I think it would be better if we give it to best, which was given by Sahala V.
Absolutely, sir.
So
one I'd like to just talk about this is that this is an appearance of subretinal fluid, but it is actually the resorption of the vitiliform material underneath the vitiliform. So it looks like CNVM,
right.
It looks like SRF, but it is not a SRF, and the clinching diagnosis is in the autofluorescence.
Absolutely right.
Okay.
So
I have one more question, which is a bit difficult, and I'd prefer if Dr. Narendra does not answer this also. He's got two. So it's a little bit difficult, but anybody who's seen this, I mean, it's not expected at a PG level, but it's a very interesting thing. Also looks like a CNVM. This looks like a CNVM. You can see a whitish lesion over there. And you can see on the autofluorescence, it looks like this. And the OCT, it looks like subretinal fluid. It looks like subretinal. So these three are three mimics of a CNVM that will make you confused with a CNVM. Does anybody have the answer for this? It's a little bit tough. So a whitish lesion pointing towards the fovea from the temporal side, that's a clue. On autofluorescence, there is a lack of RP at that particular area. And on the OCT, it looks like SRF, but it is not a neovascular process.
So one answer we got is intrachoroidal cavitation, and second is multifocal choroiditis.
Okay, so unfortunately, that would not be. It is one thing, it is not intrachoroidal, it is above the RP level. You can see it is above the RP. So one of the diagnosis potential, we could have taken FC, focal choroidal excavation, could have been an answer, but this is an example of a disease called torpedo maculopathy. It's a lesion that it looks like SRF, but it is not SRF. So these are the mimics of.
Yeah, I can understand I can understand this was difficult for all the residents, but we pointed towards the diagnosis.
Yeah.
The other eye OCT pointed towards the diagnosis of MACTEL, isn't it?
Yes, sir. Yes, sir. That's it.
So I think we are done with it. So once again, thank you, Unnikrishnan, for
Thank you.
nicely and very interestingly summing up the ARMD, especially WetAMD. You have described about, so it is important for the PGs that you should know about the pathophysiology, epidemiology, sign symptoms, the investigations like FA, ICG, OCT, OCTA, and the newer terms he has put in for all of you is macular neovascularization rather than choroidal neovascular membrane, so that you can classify it into 1, 2, and 3, and the excellent pictures. Congratulations, Dr. Uni, for showing us all the beautiful pictures. And it is very important for all the residents to identify and differentially diagnose and differential diagnosis of ARMD. He has given many, I mean, in the quiz also, he has shown you a few pictures where you should be able to diagnose and differentially diagnose what are the other possibilities in this situation. But subretinal blood and exudation in the macular area, the first diagnosis or the first provisional diagnosis should be a WetAMD. Is it? Am I right, sir?
Absolutely, sir. One of the things that should come to mind.
So, thank you very much, and Dr. Narendra and Sahala V. Congratulations.
Congratulations, both of you.
You will get the prize, and your name will be forwarded to Dr. Vishal. So, thank you, ROS. Thanks to Dr. Unni. Thank you very much. Good night.
Thank you. Thank you so much, sir. Thank you.